Welcome to everybody who's joining. We'll get started in just a couple minutes. Just a welcome to everybody who's joined us, and we'll start in just a minute. Okay, we're going to go ahead and get started. Welcome. I'm Leslie Cantor. I am professor and chair of the Department of Urban Global Public Health at the Rutgers School of Public Health. And on behalf of the school, I'm delighted to welcome all of you, whether this is your first time joining us for a webinar or you have been with us this year and in past years for our 21st Century webinar series. We're really happy that you're here and you are in for a really interesting discussion today. We're so delighted that Jennifer Reich from the University of Colorado, Denver is with us, and she's going to be talking with us about vaccine refusal, abortion access, and the meanings of personal choice in the COVID era. This is the third in our series this year, which has focused on abortion and reproductive justice. I am sure that most of you are well aware that this has been another very important week in the United States related to this issue, with the Supreme Court hearing arguments about whether there should be any kinds of restrictions placed on mifepristone, which is the main medication used for medication abortion. In terms of format, we are using a webinar format for this. You will be able to submit questions to us using the Q&A feature. And at the end of Dr. Reich's talk, Dr. Lindberg and I will curate those and get to as many of those as possible, because I know that you all will have many things you want to follow up on. With that, let me turn it over to my colleague, Laura Lindberg, to introduce our speaker.
Hello, everyone, and thank you for joining us today. It is my honor and pleasure to welcome Professor Jennifer Reich. She's a professor of sociology at University of Colorado, Denver. She earned her BA from the University of California, Santa Barbara, and her doctorate from the University of California, Davis, and also completed a postdoctoral fellowship in health policy at the University of California, San Francisco. Her research examines how individuals and families weigh information and strategize their interactions with the state and service providers in the context of public policy, particularly as they relate to healthcare and welfare. She's the author of 2 award-winning books, Fixing Families, Parents, Power, and the Child Welfare System, and a second, Calling the Shots, Why Parents Reject Vaccines, and is the editor of the books Reproduction and the Society and the State of Families. Her work has been featured in media outlets, including the New York Times, Washington Post, NPR, and Newsweek. We're really lucky to have her here today and to show us the interaction and overlap of some of these core public health and policy issues occurring in our country right now.
Thanks so much for having me. I'm happy to be part of this series, and I'm impressed with the ability to focus on these pressing issues in real time, and I appreciate being a part of it. For much of the past 2 decades, I've been studying both reproductive health rights and justice and also vaccine decision making, in part because these are two of the big questions that loom over us around individual health that trace the lines between personal responsibility and community responsibility. What are the lines between personal choice and freedoms and also obligations to those around us? And in tracing those lines, it's become increasingly clear that there's a large amount of overlap, and we've seen even more since COVID, and I'm happy to talk to you about some of it today. So in thinking about, let's see, where we are with vaccines, vaccines are seen broadly as the cornerstone of public health, and they're most effective when they're used broadly. And what that means then is that the tension between individual freedom and collective responsibility helps us shape whether or not vaccines are necessary, important, and whether they're effective. In order to balance that tension, what we see across the United States is systems where we have a wide array of legal requirements. Every state in the country requires children to receive vaccinations before starting kindergarten. And then within that framework, and this has been a story that's been shifting, all but now 5 states allow individuals to opt out of vaccines for religious or convictions that would be violated by being expected to be vaccinated. For a long time, the only 2 states that had no religious exemptions were West Virginia and Mississippi. California joined them in 2017, and for a while it was fun to speculate on any other public health law that West Virginia, Mississippi, and California all shared. But since then, a couple other states have also moved to remove their religious exemptions possibilities. Another 15 states allow parents to opt out for what they say are philosophical or personal convictions that are not necessarily religious in nature. And while historically these laws were intended really for very particular religious groups with a faith belief against medical care, what we've seen over time is that they've been increasingly used by parents who are not necessarily religious, but that the courts have supported those claims. What's important to recognize is even outside of parents who express a desire to exempt out of vaccines and still allow their children to enroll in school, what we saw before COVID was that 20 to 30% of American parents were opting out of some vaccines or delaying vaccines or coming up with schedules of their own choosing. And once we get to 20 or 30% of American parents, it's important to note that's no longer a small number or a fringe position, but that's below the threshold we would expect for vaccines to be effective by creating sort of community protections. What's interesting to look historically then is that those laws were passed starting in the 1960s as really part of a social justice campaign. They were really intended as a way of ensuring that federal funding for vaccines would go to states, and also that low-income children had access to vaccines. And this was driven in large part by the reality that the polio vaccine was inequitably distributed, that children with private insurance or private healthcare payers had better access. But that community risk of infection is shared. It doesn't stay within individuals or neighborhoods. And so ensuring that there was a public policy solution to this was important. So it's really between through the 1960s that we see that we start having these state laws, with the last states passing mandates for school attendance starting at around 1980, in the 1980s. And so it's a fairly recent moment that we've had vaccine requirements for school attendance. And at the time, they were imagined to be a part of a social justice access campaign. They were intended to make it available for anyone to have access to public health technologies. Over time, what we've seen, though, is that these legal requirements for children to participate in vaccination in order to attend school have increasingly become seen by parents as overreach or as coercion rather than justice, rather than community-based opportunities for participation. And where that's left us then is that what we know is that we are across the country seeing declining support for childhood immunizations, and that it's gotten worse since COVID. So if we look at some recent survey data, what we see over time is that the 2 questions, should healthy children be required to be vaccinated to attend public school because of the risks, the potential risks for others, and should parents be able to decide not to vaccinate their children, even if that may increase the risk, the health risks for others? And what we see over time is that the number of adults who have answered these questions has increased for support of parents' rights, even with the increased risk to others and also declining support for requirements for children. And that the partisan divide on this is most notable, that this has increasingly become a cause amongst people who self-identify as Republican or Republican-leaning, and that it's tracking on to several other kinds of conservative positions around personal liberty, freedom, and anti-state policy. What we know is that we're seeing similar challenges when we think about abortion regulation, and your last two speakers have addressed a lot of this. But when we think about where we are with abortion law, what we know is that there's about 20 states that have bans on abortion, other states that are moving towards that, some that are being litigated. And that what we know is that some states are passing protective legislation for abortion rights, but that we start to see this kind of tension about what should be legally protected, what should be guaranteed as access, and then what's personal choice for individuals to exercise that access. And we know that this is a map that's continuing to shift and change through new legal challenges and legislative strategies that we should see. But what we know is that in many states, the opportunities to exercise that individual choice that was so important that people expressed in the vaccine decision is disappearing in access to abortion. What we know that is also that having the right to access abortion is not the same as the ability to access abortion. We know prior to Dobbs that a huge number of American women lived in counties that didn't have abortion providers, that states were already seeing the erosion of care, that targeted regulation of abortion providers was creating new legal hurdles that no other physician was expected to meet in order to prohibit or at least curtail access or the ability to exercise choice. What we also know, and what Dr. Foster's presentation in the last series was about, is that we also know that cost has been a significant barrier to access and exercise of reproductive choice. And the way that this is mostly played out is that we know across the country, most people support abortion being legal, and that this number has actually increased since the Dobbs decision, but that hasn't necessarily trickled down in terms of the regulatory framework, with the greatest burden coming in terms of cost originating actually with the Hyde Amendment. And what we know from the Hyde rules was that starting in the 1980s, Title X federal funding for contraception was forbidden for being used for any abortion services. And what we know then is that for low-income people capable of pregnancy, this has created a significant burden in terms of the ability to access care and to pay for the services that they choose. And so what we know from Diana Foster's research is that the long-term outcomes of being denied abortion care are far-reaching and and are intergenerational. And so that these are not sort of academic questions about like what happens if we no longer have insurance coverage or support, but rather what does this mean for people's individual ability to exercise their choice, to exercise that liberty that people in responding to questions about vaccines seem fairly committed to. And so as we think about this, what we've seen over and over again then is political protests around the role of the state and the tension around that individual choice. What we know is that we've seen this kind of discussion around abortion starting following following attacks on Roe v. Wade in 1973, but in some of the subsequent court decisions, and as states have increasingly limited access, we've seen the kind of rhetoric of my body, my choice, the newest edition being don't tread on my uterus, drawing on libertarian tropes, that abortion is a right, and that all of this vocabulary very much hones in on the individual nature of individual choice. That the government, the state, is the greatest barrier to access, that regulation is the enemy of choice, and that often ignores that not everybody can exercise choice without facilitation of state programs, including Medicaid funding. What we see, though, simultaneous to this is very similar rhetoric coming out of the groups opposing mask mandates and opposing vaccines. And some of them are almost identical signs. At times, it's difficult to see actually what the cause is until you see the icon of the syringe. The don't jab on me is very similar, right, to the exact same kinds of rhetoric. And this also draws on very similar tropes around personal responsibility, personal accountability, and personal choice. And what we know with vaccines too is that because they are most effective when used at a community level, this kind of individual consumer choice is inadequate for addressing the largest challenges presented by infectious disease. Both movements assume that less regulation and more personal freedom is the answer. But we know that that's not entirely true. And we saw this during COVID in terms of access to vaccines, in much the same way we've seen the barriers to access to abortion services and family planning services, that without investment, without public infrastructure, without distribution, it was hard for people who wanted to choose vaccines to also get access. And this isn't new from COVID. We shouldn't have needed COVID to remind us of this, because reproductive justice advocates have been arguing for a long time that individual choice is not the same as the ability to exercise choice, which requires resources, and that we find ourselves in a landscape that individuals have about as much choice as they can afford. Underlying all of this rhetoric of individual choice and personal freedom of state involvement is the rhetoric of personal responsibility, that people should be able to make their own choices, and that when bad outcomes happen, it reflects a lack of personal responsibility and that kind of individual accountability. And this isn't surprising, because this rhetoric surrounds us everywhere. And here's just some of the ways that we've seen both parenting and health promotion focus on personal responsibility, with much of this narrative actually coming from public health agencies and governments. School, whether it's choosing the right school, counting your calories, counting your steps, taking responsibility for being an effective contraceptor, all of this kind of rhetoric of personal responsibility underscores that sort of individual freedom, but also individual responsibility, at the exclusion of explanations that are about the limitations that lack of resources and community opportunities often present. But this is a persuasive vocabulary, and one we see ubiquitously. In my research with parents who opt out of vaccines, over and over again, parents explain to me how hard they work to promote their child's individual health, which replaces the needs for vaccines, that health is a personal project, and that disease is avoidable if people work hard at it. And of course, this is scientifically untrue, that much of illness is not personally mitigatable. Infectious disease might be the purest example of this, where no matter how good your nutrition is, that doesn't necessarily protect you from the risks of exposure to infectious disease, or predict who's likely to have the most deleterious outcomes of infection. And we saw that during COVID a great deal. That usually people would talk about their very healthy friend who had a terrible experience or was hospitalized, and someone else who presented as having poor baseline health, who handled infection fine. But the story that this individual personal responsibility can determine health outcomes is powerful, and is relatively ubiquitous. So from the story I'm telling you so far, what we would picture then is that we live in a world where those who oppose vaccines and those who support abortion rights are finally agreeing, that we have a united front around this kind of personal liberty story, and that we're going to work together to make sure everyone has personal freedoms. And of course, this is not how the story is going. In fact, what we know is that the people who are most opposed to both abortion and availability and vaccines self-identify as conservative, Republican-leaning, and evangelical, and that those are the best predictors of who did not receive vaccines during COVID, and also who's most likely to oppose legal access to abortion services. And in thinking about all of these questions, the spaces then of why there's this disagreement, even if the fundamental cultural underpinning is the same, deserves closer evaluation. So what I'm going to spend the rest of my time talking about then is how abortion politics and this anti-abortion rhetoric has created an underpinning that those who oppose vaccines have been drawing from and trying to link explicitly as a way to discredit vaccines and the claims that they're safe and necessary. So our story actually begins in the 1960s. And this is the very beginning of the linkage between abortion politics and vaccines. And they've been inextricably linked in ways that are not entirely visible ever since. And so in thinking about what this means, what we know is that not all viruses can replicate on all kinds of tissue. And that in order then to create vaccines, scientists relied on tissues that was created using fetal cells. And so here's like a very crude diagram of what that looks like in terms of taking fetal tissue, isolating tissue from the kidney, isolating it down to a cell level, growing or replicating viruses on it to identify the possibility of creating vaccines. And then those cell lines became replicatable over time exponentially, which is important because cells have usually a finite amount of replicatability, which is limited scientific enterprise. And these cells are more dynamic. And for many people who have been following controversies around some of these cell lines or the story of Henrietta Lacks, we know these have been significantly important within the scientific story and also raised questions about their ethics and moral usages. Now, the cell lines are not taken a fresh batch from each fetus for each line, but in fact, these immortal cell lines have been really important and replicatable now for decades. In terms of thinking about what their role has been, the original 2 cell lines from the Wisteria Institute and a British cell line were used to create a range of vaccines, including against polio, hepatitis, rubella, which is German measles, chickenpox, including shingles and rabies. And conservative estimates actually are that they've prevented more than 11 million deaths, and that they've probably treated or prevented 4.5 billion cases of diseases. And so the significant role of these cell lines in terms of their contributions to science is significant, but they absolutely originated from fetal tissue. And they were not pregnancies that were terminated in order to gain access to medical research, but in fact were pregnancies that were terminated and then those cell lines were isolated and developed. But nonetheless, they've been sort of a part of the story of moral objection around what it means then to use the vaccines created from this. So in thinking about then what this means for the interplay between fetal health, abortion politics, and vaccines, what we know then is that infectious disease is terrible for fetuses and terrible for pregnancies. And the greatest example of that is around congenital rubella syndrome. Congenital rubella syndrome is the result when a pregnant person or woman is infected with measles and during pregnancy, and it was prior to vaccination, the leading cause of congenital deafness. It can cause corneal damage, brain damage, deafness. And in epidemic years, it was responsible for more than, in 1964, it's estimated that 20,000 cases of congenital rubella arose, resulting in 2,100 neonatal deaths, 11,600 cases of deafness, 3,500 cases of blindness, 1,800 cases of intellectual disability, and over 11,000 miscarriages from one outbreak year in 1964. So congenital rubella syndrome is important in terms of the outcomes for fetal health for those who wish to continue pregnancies. But also, prior to the decriminalization of abortion services, the one way to access abortion was through hospital review committees. And those hospital review committees would take a woman's request for an abortion and evaluate it. They were tend to be humiliating. Women were expected to go in front of a board of men who were hospital administrators and practitioners to present their case. And exposure to measles was often presented as one of the rationales for why a woman said she needed to terminate her pregnancy. This created tensions within the medical field that vaccines solved for them. So the availability of a measles vaccine removed the conversation of whether or not this was a worthwhile abortion, whether the exposure was real or whether a woman was making it up. And it created the possibility then of avoiding these politics with the measles vaccine in the 1960s, about a decade before Roe v. Wade. And so it created the opportunities to start to solve this in terms of the politics of healthcare itself. Similarly, rubella is a disease that is a mild infection for the person infected. It doesn't feel significant. It's usually cold or flu-like symptoms that are short-lasting, but it's a significant risk to fetal health and development. We also know chickenpox can create chickenpox exposure early in pregnancy carries a 2% chance of having a fetus with some kind of development of physical abnormalities, sometimes scarring of the skin, limb deformities, eye damage, and intellectual disability. There's a range of diseases. We know that during COVID, for example, estimates are that vaccines to women who became pregnant or were pregnant prevented about 5,000 miscarriages each year. We know infectious disease is bad for pregnancy, and vaccines have been a tool for promoting fetal health. Because of that, what we've seen then is that major religious organizations, including the Catholic Church, which has a strong position against abortion, favor the use of vaccines, even those derived from fetal cell lines, because the greatest good for fetal health is vaccination, is prevention of an infectious disease. And so we've seen this as a powerful way that vaccines have gained support, even among those who are critical of abortion. You would think that then that would settle the question, right? These cell lines have been around for more than 50 years. They've been instrumental in protecting pregnancies and protecting fetal health, that they've been a powerful source of prevention, and that they've alleviated many of the tensions within the medical profession itself from having to decide about abortions. And as you know, that's not where our story takes us. And so thinking then about how do we understand the consistent and ongoing opposition to vaccines, even amongst those who describe themselves as evangelical, describe themselves as committed to pro-life ethics, and who passionately oppose abortion. What we see then is that claims about these cell lines about abortion politics then get deployed as ways of further undermining vaccines in ways that on the surface seem outlandish, but have actually been powerful in helping people question the morality, not just of the vaccines, but of the people who choose to use them. So here's a few examples of how this has happened. We see a lot of rhetoric that that the use of vaccine is immoral because of the use of those fetal cell lines. And what we know is that it's not that the information is presented that these are ancestral cell lines from a long time ago, but rather that every vaccine includes fetal body parts, that vaccines include fetuses, and that the use of them is the same as supporting abortion. And so you'll start to see this kind of rhetoric everywhere in terms of the DNA of aborted fetuses in those vaccines. And that this allows for the possibility that those who use vaccines are supporting abortion and exercising a certain kind of moral corruption. As an example of this, one anti-abortion organization explains the culpability in abortion that resulted in vaccines and the problems of using them. It writes, "The fact of the matter is that ascertaining moral culpability, it's not just the mother's intentions that must be considered. There are three parties involved: the mother, the abortionist, and the researcher, all of whom share equally in an intrinsically evil act. We know it's the intention of scientists to destroy embryos for research purposes. And likewise, it was the full intention of both the attending abortionist and the researcher present at the foot of the abortion table to destroy those babies specifically to create vaccines." The parents I've interviewed in my research often cite the presence of fetal cells as part of their discomfort in their explanations of their objections to vaccines. One mother explained to me, "The chickenpox vaccine has evil human cells of aborted fetuses, and a lot of Christian people I talk to are just amazed that this is happening, and they don't even know because it goes against their sense of what's right, but they're not even being told that that's what they're doing." This kind of rhetoric around this immorality has proliferated and been endorsed by a range of public figures, including Kanye West, who in opposition to the COVID vaccines, the Johnson & Johnson vaccine did use these cell lines, and the Pfizer and Moderna vaccines tested the efficacy of the vaccines against cell lines, even if the cell lines weren't used in the vaccine creation. And that led to this new opportunity to highlight the intrinsic immorality of participating in vaccination as a Christian. There's also been efforts then to claim that those who choose to use the vaccines are supporting immorality akin to cannibalism. The argument goes as follows. As one blog writer writes, "Isn't the definition of cannibalism the intake of flesh, blood, or some body part of your own species? How much of a difference is there between eating human tissue or allowing it to be injected straight into your bloodstream? Of course, there are medical emergencies where people need blood or organ transplants and adopt another person's blood or tissue to survive, but vaccines do not fall into that category." Now, on the surface, this kind of discourse sounds wacky. It sounds fantastic, and it sounds like it would be uncompelling, but in fact, it's been fairly powerful. The power of the rhetoric is twofold. It accepts that fetal cell lines are the equivalent of a person. And so once we make that cognitive leap, that that a single cell could be the equivalent of a full person, it allows then a certain level of disgust and at a visceral level to take hold. Second, it allows for the use of images of a repulsive practice to create a kind of moral boundary. So it allows for those who support vaccination or choose vaccines to be seen in a category of those who have crossed certain social boundaries and certain kind of violation of social norms. The kind of rhetoric then around these cell lines and thinking of them as full people has been really powerful in linking to other kinds of causes, not just abortion, but also attacks on the increasing visibility of transgender children and people who are queer. And this takes a few different, this sort of plays out in a few different ways. The core of it is that the increasing visibility of people who are queer or children who identify as transgender is not increased visibility so much as an increasing number. And that must be because of the increasing use of vaccines. To link these takes us all the way back to the 1960s cell lines. One of the ancestral cell lines was created with a fetus who was genetically female, and one was created with a cell line that was genetically male. And so how these often reproduced posts go is they ask, how does human DNA and vaccines contribute to the rise of gender identity confusion? The WI38 is the cell lines from a female aborted fetus used to cultivate viruses used in vaccines. When you inject DNA from a female carrying 2 X chromosomes into a male who already carries 1 X chromosome and a weaker Y chromosome, you now have an overload of the X chromosome. Now we have an onslaught of boys who think they should be girls. Do we have male DNA vaccines? Yes. The MRC5, which is the British vaccine cell line, is the code given to the fetal cell line, also used to cultivate viral components, and it comes from a male aborted fetuses. Do we have girls thinking they're boys? Yes. Is it as prominent as boys wanting to be girls? No. Why? Because girls have 2 dominant X chromosomes. When they're injected with a vaccine containing MRC5, they aren't just getting a Y chromosome, but another dominant X chromosome on top of the 2 they already have. That's why you don't see as many girls wanting to be boys as you do the other way around. Related to this, the website Christians for Truth explains, getting rid of the dangerous and ineffective vaccines, and you will get rid of the dangerous and ineffective vaccines, and you will greatly reduce gender confusion in children. But we can't have that. And even if vaccines were shown to cause transgenderism, the LGBT community would come out and firmly behind increased vaccination rates for children, as it would be yet another way to increase their numbers. So these claims are tightly woven with homophobia, with gender discrimination, but also with racism, misogyny, and anti-Semitism. Related to all of this is comments about the scientists themselves, many who were Jewish. One online comment references the number of Jews involved in research and education specifically, saying, yep, Jews sell the vaccines and run the transgender propaganda machine. They have kids coming and going, and you want to argue which tentacle of the Jewish octopus is the most lethal? Sounds like Talmudic hair slitting to me. And so throughout this kind of rhetoric, the lines that can trace from the original abortion cell lines through a range of cultural war front lines is exploding and increasing regularly. And when these images first started showing up, I was fairly convinced that they would remain on the fringe, and they've increasingly shown up as more and more mainstream as we've seen a rise in things like legislation against trans rights, limiting the use of bathrooms in public spaces, limiting the resources of children in schools. And that this kind of rhetoric then has found a new home in linking the straight line between opposition to abortion, the importance of fetuses as people, and then all the way through the ways we can think about this as supporting a racist and homophobic agenda. So at a more material and less symbolic level, this rhetoric has been really helpful for parents who wish to opt out of vaccines from that legal requirements within the states of the map that I showed you, by allowing them a vocabulary to claim a religious exemption. Many of the parents I've studied and in the discussions that I've analyzed were not necessarily religious themselves, but saw a religious exemption as their best path for making a claim out of the requirements that their children receive immunizations for school attendance, even though they wanted their children to stay in school but not participate in community health. As they offered advice to each other, I saw parents make claims where they explained how to write their exemption statement. One said, if the MMR mumps use aborted fetuses or something, you might be able to say it's against your religion. I don't remember which ones do or don't, but even being Catholic could allow you to slide out of that one. Another mother posted in a discussion board that she had already consented to some vaccines, but had changed her mind and was afraid that she would no longer have access to an exemption since she had already begun the process of vaccination. She was reassured by others, it's okay, you can always find Jesus. What's important to note then is that these parents do not see themselves as harming others. They continue to see from where we started in our talk that vaccines are an individual consumer choice that reflect personal preference rather than community obligation and support. One mother explained that she doesn't see that how she's harming others. Rather, the ability to exercise a personal choice is under siege and makes them the victims of this kind of rhetoric. One mother explained in an online discussion, the worry about getting into schools, having to be careful about how we formulate our own religious exemption letter, the constant politics regarding consent in schools, it's awful. I feel like I'm walking on eggshells sometimes. I just hope that people can humanize everyone's personal choice and leave it alone. That's a really persuasive kind of vocabulary that we see in lots of other places, but of course it ignores the reality that vaccines are most effective when used collectively, and that as individuals opt out, everyone, those vaccinated and those not, face increased risk of infection and disease spread. So how has the state responded to this kind of vocabulary that we're seeing at this moment? So if we bracket abortion for a moment, because we know the legislative state of that, which may become significantly worse based on how the Supreme Court decides on the use of both the Postal Service and pharmacies and FDA regulation, a decision we expect this summer. If we put that aside for a moment, we can ask questions of how has COVID and the environment that supports increasing personal freedom from vaccines affected the legislative environment. So what we know is that in the past year, we've seen proposed legislation that has not yet passed that would have banned the administration of vaccines and sometimes criminalized its use. So North Dakota proposed a law last year that would have banned the administration of mRNA, of vaccines in general. And Idaho proposed a law that would have made it a misdemeanor to give an mRNA vaccine specifically to any mammal. So presumably this would affect veterinarians as well, who have a mRNA vaccine under development for rabies. These laws mimic anti-abortion legislation that criminalize healthcare providers and create increasing burdens for the kind of medical practice that they want to do. A more recent study by Michelle Mello and colleagues identified 65 laws adopted in 24 states between January 1st, 2021 and April 2023 that have created restrictions that were intended to be about the pandemic, but have far-reaching effects. So they identified two categories these laws fall into. And so what we can see within these restrictions is that they fall into they lump them into two categories: restrictions on state and local officials' powers to institute community mitigation measures and laws that tighten the timelines and the use of community mitigation powers. And so in the first group, what we see is a range of laws that prohibit requiring vaccines or requiring proof of vaccination, that expand opportunities for exemption to vaccine requirements, that limit officials' abilities to close businesses or schools, to limit or restrict state authority, to limit the participation of meeting of religious organizations. Some states banned or impose hurdles on the use of masks or mask mandates in their communities. Some have limited the governor's powers to suspend statutes in case of an emergency. Some bar stay-at-home orders completely. And at least 8 states have laws that clarify that local governments cannot pass stricter mitigation measures than the state's measures. And that's in response very clearly to individual communities that decided to take their own approach to mitigation at the community level. In the second group of laws, what we see is that we see laws that are limiting the powers of mitigation or altering the process. And these tend to be limits on time. So it reduces the number of days that a declaration of an emergency or emergency order can last. Some as short as 7 days, which those of you who study infectious disease know 7 days will not be particularly helpful for curbing infection. Some add provisions that the legislative body could terminate the emergency declaration at any time. 6 required officials to articulate the reason for the declaration on orders, And 10 require that if these orders come to a court review, that there should be a higher level of scrutiny when evaluating the orders. And many of these focus specifically on stay-at-home orders and limitations on work and school. These kinds of laws were intended very clearly as a response to the mitigation efforts during COVID. But as we move forward and think about future kinds of infections, we can see already that these laws are having broader impact. Last week in Florida, Florida is experiencing a measles outbreak. And we saw this letter from the Florida Department of Health go to elementary school parents. In this letter, which is available if you're interested online, it says, once again, Florida has shown the good public health policy, that good public health policy includes personal responsibility and parents' rights, according to Ron DeSantis. While the national medical health establishment and media have lost the public's confidence, Florida continues to restore sanity and reason to public health and will always do so under my leadership. What this means is that the letter that went home said that even though the CDC and other agencies recommend that unvaccinated children be excluded from schools during times of measles outbreaks, the state of Florida will not require it, and that it'll be an individual parenting choice. As their state surgeon general explained, it's important that public health leaders consider all available data and make decisions that promote health while respecting the rights of individuals. Under the leadership of Governor DeSantis, I will always serve with integrity and prioritize a holistic approach to public health that tunes into the needs of Floridians and tunes out the noise. Thinking about what we mean by noise versus individual freedoms, what we identify quickly as community obligation. And that we saw when California, for example, withdrew its religious and personal belief exemptions from state laws, the pleas of children's families who had children with cancer and compromised immune systems who couldn't safely attend school in communities that had low rates of vaccination. That the way we take care of those who are most vulnerable around us is through participation in community mitigation. And yet this vocabulary of parents' rights and individual choice speaks directly and it's fairly aggressively against that kind of thing. The outcome then is what we'll see. Moving forward is increasing efforts to define civil rights for both people who are unvaccinated and for fetuses themselves. So what we could seeing this play out in a few ways. About half of states in the last 3 years have considered some kind of legislation to define unvaccinated people as a protected class akin to race and sex. These laws forbid government and private entities from discriminating based on vaccination status. And so far, Montana is the only state to have passed one of these laws, but the fact that they've been presented and introduced so broadly speaks to the desire to see vaccination choice as the same as an immutable characteristic on which inequality and discrimination has often been built. Efforts to make inequality the same as personal choice and behavior as the same as group membership is a significant change in how we think about civil rights. At core, it serves to erase race and sex by extending it so broadly that it becomes meaningless. And this is not an accident. One supporter of a bill in North Carolina explained, "It's nothing other than a civil rights issue. It's no different from no vax to no service, no different from no whites to no service, no different from no blacks to no service. It's the same thing. It's the same as no trans, no service. It's discrimination." Not only that, but they put the non-masked people on one side, they put the masked people on the other side. This is no different than the Civil Rights Act of 1964, which is a law that protects all of us and our liberties. So as we think about then what this means, what we see simultaneous to this is a call for civil rights to be extended to fetuses as a way of arguing against access to abortion. As unvaccinated people request civil rights protections, others are arguing that embryos are also the same. In Georgia, a legislator successfully advocated for a law to ban abortion once embryonic cardiac activity is detected, known as a heartbeat bill, which is often as early as 6 weeks. And they argued it by arguing that fetuses should be receive civil rights protections just like Blacks and LGBT Americans. In pointing out how Roe v. Wade was a mistake, he likened embryos to Dred Scott and asked legislators to define fetuses not as 3/5 of a person, but as a full person in law. Last year, a Florida attorney filed a writ of habeas corpus on behalf of a fetus, arguing that his pregnant client should be released from jail ahead of trial since the fetus is a person and is being subjected to unlawful and illegal detention. And in 6 states, lawmakers are proposing measures modeled after Georgia's law that grants women child support starting at conception. Utah followed Georgia in this and is another state that grants a tax deduction for fetuses in their state tax code. 4 other states are considering similar bills at this time. And I'll just wrap up by saying we have a new entry. So maybe this is a little bit of a postscript. But as we think about these personal vocabularies, our latest new entry to the conversation is those who support in vitro fertilization. It's worth highlighting that this is going to play out since the Alabama case in very interesting and I think it'll be surprising ways. It's worth noting 2% of all births in the US are conceived by IVF. Historically, this has been an entirely unregulated market, with physicians asked to be self-governing. In opinion polls recently, 86% of people think IVF should be legal. More than 40% of Americans say they know someone who's received treatments for fertility, and about 10% of American women report seeking kind of medical support for fertility. In fact, most Americans want access broadened, not foreclosed. And that 10% of American, no, it's more, 60% say that fertility treatment should be covered by insurance. And that number is even higher for women and people under the age of 40. Arguing for no regulation hasn't worked for abortion or for vaccines, but regulation has been seen as a way of protecting freedoms and also foreclosing them. So as we think about how IVF and the new front of legislation is playing out, it's clear that IVF is a question for people who are whiter and wealthier than those who worry about abortion access. And that may change the scope of how it gets discussed, even as the Catholic Church passionately opposes IVF in ways that they don't for vaccines. So I'm just going to conclude by offering a couple paths forward. So one is, I would say that we should we have to collectively watch for efforts to glorify personal choice. And we should work to reject individual frames for public problems. That we know health promotion, reproductive justice, access to healthcare, prevention of infectious disease are not individual problems, they're collective problems. And every time we hear calls for more personal responsibility and individual choice, we should question what public investments and supports we need to support those kinds of opportunities. We should watch for claims of religious freedom if they're based on the claim that others' efforts to live authentic lives are presenting harm to them personally. And we should watch for those kinds of claims that elevate some individuals' preferences over other people's ability to live safely. We need to watch for ways public health can be reduced to a series of consumer choices available to those with the most resources. We see this with vaccines, with HIV prevention and PrEP medications, with trans healthcare, with contraception, and with abortion. And we should be vigilant against accepting that resources should determine who has personal choice and how it can be exercised. And one final challenge that's the hardest and maybe the most important is for us to remain vigilant and united in how we face racism, misogyny, anti-Semitism, homophobia, and ableism together. So we have to avoid using vocabulary that inadvertently furthers inequality, particularly as agency officials, researchers, and experts. And we see that inadvertently, this kind of rhetoric can find its way into public health messaging. Vaccine rejection has a certain ableist logic within it. And we've seen sometimes abortions built on the reasons that some people have a good reason to terminate a pregnancy, namely the possibility of disability, and other people then by implication don't have a good reason. And thinking about this as how we move forward as a public health structure that supports individual choice and the ability to exercise it requires us to reject the logic that there are some good reasons and some bad reasons for exercising choice and accessing healthcare. And that, in fact, everyone who's an expert on their own lives has good reasons, even as it might require public investment to support it. And I'd say above all, we need to watch for ways we're encouraged to see each other and to see movements as separate or even in competition, and rather to see the points of connection where all individual choices and personal liberties can be supported through community work together. And I'll stop there so we have some time to talk.
Thank you so much, even though I feel like in some ways this took my breath away. I think you did such an amazing job bringing together these forces. And I do love that, you showed how these opposition to public health and civil rights forces are quite intersectional, and that our opportunity is for us to remain intersectional and not get siloed. So, we have a number of different questions. I think, you early on and then later came back to this idea, though, that in public health, we sometimes lift up the tools we've got. And sometimes those do feel individual, even though I think we've really moved to understanding that systems and structures are really big determinants. But I wonder if you might say a little bit more about what to do about that, because I do think people in communities don't want us to say there's nothing you can do. And at the same time, we have to be really careful because this personal responsibility, and if you just have good health, nothing will hurt you, that's very ascendant.
Yeah, and they're complicated because this rhetoric is not just from agencies or medical providers. It's also woven into advertising campaigns and commercials and apps and everything in our daily life that's marketing to us health promotion, right, is really building on this. And so it's so deeply ingrained and surround us, it's really hard to question it. The best ways I think we can point it out at the individual level is we can highlight the ways that we jump to conclusions about people's health when they experience bad outcomes. So we frequently were like, how could they have cancer? They're so healthy. How did they have a heart attack? They're a vegan who jogs every day, right? We've already accepted that there's a morality to health promotion. And what that allows is for people who are experiencing chronic illness, who are experiencing disability, to be seen as somehow morally failing. So we should all be better at recognizing that and calling it out. I think about choice a lot, particularly as it informs the landscape of parenting. And so we know things like school choice are based on the premise that it's okay that some children have failing schools as long as your children don't have to attend them. And we should question that premise. Why is it okay that any children have failing schools? Why is it okay that some children don't have resources and some do? And we've, I think broadly, particularly starting in the 1980s, accepted that there's a zero-sum game, that some people can have health and nutritious food and clean environments, and some people can't, that some people can have high-performing schools with PE every day, and some people can't. And I think we should question whether we really do have to have a zero-sum game on this, right? And what does it mean then, as public health researchers and practitioners, to raise this question of like, what does it mean to really create opportunities across our communities without it saying like, we're not taking it away from you and forcing you to attend the bad school, but rather what does it mean if we lift everyone? And I think there's opportunities to reinsert some of that. What's clear to me at a public health level that's outside of my talk that I've been thinking a lot about is that there's a certain level of lack of belonging and despair people are experiencing. And I think that there's an opportunity to also address that sense of anxiety and isolation by reframing a lot of these conversations, and that could be its own public health benefit.
I want to ask a follow-up question that's related to that came in through the Q&A, because it asked about what feels like a seeming paradox where religious people are dismissing requirements that go directly against what should be what we would think of as a religious value of caring for community, and that you would think religious people would hold that value. So how do you balance what's happening? Is that a paradox here?
It's like, it has become fascinating to sort of see during COVID as an example of how different churches responded to mitigation strategies. And that there were discernible and clear efforts in some churches to highlight that taking care of all the members who were vulnerable was part of their work as as a community group. And then some who felt like it was very clearly an attack on their religion to ask them to take care of mitigation strategies. And to see those kinds of divisions are challenging, in part because the sense of what's been dubbed like the war on Christianity has become a political talking point that's been used against multiculturalism, pluralism, to think about sort of the multifaceted ways. And we see this every season at Christmas time, and attacks on Starbucks cups for no longer wishing people a Merry Christmas or using like whatever the different rhetorics are. So it's serving a certain kind of political opportunity, right? That's enlisted a fair number of conservative churches involved in that campaign. And that's allowed them to move away, I think, from some of the more fundamental beliefs around care. I think this is one of the greatest questions that we have going forward, is thinking then about how do we bring diverse organizations who, if you sat down, would have similar kinds of values. But what does it mean then to care for the people who are different than you, who are outside of your network? And I think that this has become an increase, as we talk, there's lots of conversations about the increasing partisanship around us. But I think we can also think about the fractions and the fractures around our communities. And what does it mean then to build coalition? What does it mean to sort of build opportunities for the points where we overlap and the points we don't? And in many ways, this is stretching my thinking too. Like I've been thinking about would I be willing to form coalitions with anti-abortion organizations to get childcare extended, to get better access to healthcare for women and children? Like what are the coalitions really meaning, and how much do we need to have that perfect value alliance? I think are really hard questions. And while COVID was probably an opportunity where we could have found more common ground, based on how we saw the story roll out politically and socially, it actually went the other direction, which was that we were supposed to then increasingly see other groups and people in competition with ours. And that allowed, I think, for more distance and not more ties together.
Yeah, I mean, this was one of the things I was thinking about when you were showing all of the legislation that's actually going to, put a hole in public health forever in this country, that we thought, I think, that the pandemic and people understanding that having a weak infrastructure, we thought that was going to mean more stable funding and more appreciation. And here we are, opposite. Um, we have a question in the chat about whether the medicalization of public health has perhaps led to some of this, and the fact that there are a lot of sort of physicians who are oriented towards the one patient, whether that is something that you think has been a contributor.
Public health as a discipline, I think, has some challenges. And I'm not a public health practitioner. I just get invited sometimes to hang out. So it's easier for me as a sociologist to say this than I think it is from within the kingdom. But there was a point probably starting around the 1970s where this framework of personal responsibility really took hold. And I could think of the jogging craze and Jane Fonda and aerobics and this like vocabulary, right, that you could personally mitigate health. And I think what we saw in public health campaigns was a shift also towards more personal individual mitigation and or behavioral changes rather than community level change. And the limitations of that approach became very clear when we saw things like the Flint water crisis, when we've seen the problems of air pollution in communities near highways, right? When we think about some of these like broader questions, there's no individual mitigation strategy that can solve lack of drinking water, right? And that's really that's the sweet spot for public health historically, has been the ability to deal with community level change, to think about that kind of public part of it. In terms of then what that means for the practice of healthcare, we actually have less individual healthcare than we ever have. The individual doctor appointment has gotten shorter and shorter. Fewer people see the same provider at every appointment as doctors increasingly have large groups and different kinds of call schedules. And so there's actually less individualization in healthcare, which you think then would maybe make people feel differently about it. What I see in my research is that actually that's one of the drivers then of distrust of expert opinion. When it comes to things like vaccines, parents will say to me, this person's met us for 15 minutes twice a year. How do they know what we need? How do they know our nutrition and our lifestyle and the way we live our life and what our risks to exposure of disease are? Like, I trust myself more than that. And so in some ways, it's actually the breakdown, I think, of opportunities for those conversations to really underscore the part of the community that resonates. What's important to recognize, though, is that people are not unkind, and that I'm consistently impressed by the generosity we see. And we saw this during COVID too. We saw people buying groceries for their neighbors. We saw people dropping off packages and banging pots and pans or playing music every night to cheer people up in their neighborhoods, right? Like we saw ways that people work together when given a vocabulary and an opportunity to do so. And it's true for vaccines too, that there's evidence that when people understand that they're protecting their family member who has an autoimmune disease, or their child who had a bone marrow transplant, which one of the participants in my study who changed their perspective on vaccines, right? Like thinking about what are the opportunities, we know that people actually are open to care, right? So it's not that this individual perspective is unyielding. It's that people tend to be more aligned with those they know and recognize as the people they want to advocate for. And so I think that question again of like, how do we restore belonging and connection, I think can potentially lead to huge acts of generosity too.
We promised people would be done at 12, so I want to let folks go. But with enormous thanks to you, Professor Reich, this was so fascinating, and the connections between how abortion policy connects to so much other public health policy, I think is really eye-opening for folks. I do know what people would love to leave with, and maybe this is too much to ask, but what's the two-sentence things people can say? How do we walk out of this with a message, with the ability to message about how to protect abortion rights and the need for vaccines and public health?
You know, one of the things that was really profound to me was one of the first talks I ever gave before my book came out. A parent showed up who was really angry, who felt her child had been vaccine injured. And what seemed really clear to me at that moment was that it's not my role to say your child, it's probably correlation, not causation. And instead, what I wanted to say to her was, I'm so sorry your family is struggling. And I think that there's these ways that instead of we can surrender being right to be kind sometimes, and that allows for different conversations on what we know is that when people have family members and friends who need abortion services, they support abortion services, even if they're uncomfortable with it philosophically. And we know something very similar about vaccines and other public health outreach. And I think there's opportunities then that we can surrender some of the space about being right to be connected. And I think that there's ways we can all do that moving forward. And I so respect the folks in public health who are on the front lines of agencies. Of all the things that were not on my bingo card for 2020 was the sheer volume of attacks and on public health agencies and workers and experts. That was not something I was expecting to see. And the fact that you're all here at a webinar and pushing forward, I really appreciate, because I understand the battle is hard and tiring. But I think that the rewards might be significant. So I think that, I don't know if that's quite the right answer, but people are experts on their own lives. And I think everyone's doing the best they can where they are. And the more we can understand where they are, I think the more opportunities there are to move together.
Thank you for that. And thank you everyone who's attended this and our earlier seminars. This is our last for the year, but we will be emailing you in the fall with speakers that we'll be inviting in for our 21st Century Health seminar here at Rutgers. So we hope you'll join us next year as well. Thank you, everyone.